Like, can you see this image over here? In this, you're separating the gingival tissue from the underlying bone. Outside, if you see, if this was closed, it looked like a beautiful case as if the patient had no pain, nothing. But when we open the flap, plastic surgeries, especially in periodontal plastic surgeries, are referred to those areas where you're improving your aesthetic conditions.
Do you enjoy learning without distractions? Download our app now.
Good evening, everyone. I'm Dr. Fahizah. I'm a periodontist and I love teaching perio. So I think that's why I took up this. But actually, perio as such is a very beautiful subject, and I want to make it easy to you guys. Like, you need to understand, especially when we are in a college setup or a clinical setup or any kind of academic setup. What happens is we are stuck to one kind of learning, that is what they teach, and that is correct. But sometimes you don't get the concept. Even when you're reading the book, you can't correlate it to the clinical aspect of it. Like, how does it look clinically? And that's where I struggled the most. Like, I used to read the textbook, but I was like, I know periodontal flap, I know this happens, but how does it actually happen in a patient? So that is what I think we are looking into, like where we are trying to maximize the connections between what theoretically is given and correlating it with the clinical look of how it looks or how it is done. So this is going to be a series of only for periodontal flap, because after the discussion, we understood that a lot of you have doubts on the periodontal flap and how it's done, why it's done, even the basics of it, like what is it. So for that sake, it's a vast topic. So we have divided into like 6 series. Each week we'll be like covering one topic each. Today will be the introduction part, very basics, and we'll see how we can go about it and what are the questions you have. We can answer it accordingly. I'll just share my screen. So first of all, what is a periodontal flap? Okay, a periodontal flap, it is the section of the gingiva or the oral mucosa which is surgically separated from the underlying tissue. Like, can you see this image over here? In this, you're separating the gingival tissue from the underlying bone. So that tissue which you're separating, it's like a flap, right? So that's why they call it as a periodontal flap. Now, why it is done? Basic idea is to get access. When the tissue is covered, you know X-ray you're taken and you know there is a defect over there. But how do we, get access to that area? That's why we elevate that area, like open up the flap. Now, how do we open up the flap? Again, there are different incisions given. You can either give straight and open up, or you can give two vertical and like a flap, like on two vertical sides and then open up, or nothing, like no two vertical incisions, only in the sulcular region you can place your scalpel and then lift it up. So there are different various kinds of flap which are there, which we'll be discussing in further discussions. But as of now, this is the basic. So the gingival tissue which you're lifting up, that is called as a periodontal flap. And why it is done? Basically to access the root surfaces. Can you see over here? You can see very clearly this is the bone and these are the root surfaces. All that we covered. Now, after opening up, you can either, if there is a defect over here, you can do something about the defect, or you can clean the root surfaces. It is called as root planing. So root planing becomes easier. So in general, if you want to do only a deep scaling and deep subgingival scaling and root planing, what we call it as an open flap debridement. That means you open the flap, you debride it, you're not doing any other kind of procedure on it. That becomes your open flap debridement. Okay, that is the basic surgery which everybody does, like most of the periodontist does on a patient whenever there is deep periodontal pockets. But in support to that, there are different various other kinds of surgeries which are available as well. undisplaced flap, displaced flap, papilla preservation flap, modified Widman flap. All that we'll be discussing in further discussions when we have. But what is a flap? It's a section of the gingiva or the oral mucosa which is surgically separated from the underlying bone to provide visibility or access to two things, that is the bone and the root surfaces of the teeth. So let's see why this flap is done. We know accessibility is there, but why exactly? Like, why do you need, what is there inside the flap that needs to be like, so much of opening needs to be there? First of all, to gain access to the periodontal pockets. In this case, if you see, outside, if this was closed, it looked like a beautiful case as if the patient had no pain, nothing. But when we open the flap, can you see this such a deep pocket over there? It's a 9 mm pocket, which is seen in this case. But aesthetically, if you see, there is absolutely no problem. Like the gingiva is covering beautifully. But we know that there is a pocket after seeing the X-ray. But how to get access to it? That's when we open the flap. What is the other reasons? To remove the tissues. So when we open the flap, you can see these granulation tissues over here. So these tissues are infectious tissues, granulation tissue. It is different bacteria are there and different root deposits are there, all combined to that along with the blood vessels that makes up the granulation tissue. That comes in another chapter, which you guys can later go and see also. What is a granulation tissue made up of and all that. So to remove those tissues easily, you need to open the flap. So when you open the flap, all the diseased areas like these granulation tissues and all, nicely you can take it out. You can plane it. Now, if I take this case, actually this case has a problem because when you're opening the flap, if you do only so much of opening, you're not able to get the entire access to your whichever area you want. So I would suggest a little more opening of that flap because the major aim of opening a flap is to gain accessibility and access to the root surfaces and the diseased tissue. So if anything is hindering that, like if you have done it half or something, it doesn't make sense, right? So you need to open as much as possible where you get enough accessibility and visibility to the areas which you are treating. Next is to regenerate the lost bones. So even for those kind of flap, like when you're adding bone grafts, you open the flap. So this is another indication. Where else? This is to do recontouring or modifying of the bone. So that's when you lift the flap. Then comes to prepare the mouth for prosthetic work. Right? In this teeth, you have to place a crown. So when you place the crown, you know that it is going to go below the gingiva. So you need, what happens is there is no space. So you open up the flap, you reduce a little bit of bone around in this region. Like over here, you reduce a bone little bit and then you close it back. So when you place the crown, you have enough space to improve aesthetics. Now in this case, there is recession in this case. So you have to treat either with any kind of tissue grafts or bone grafts or whatever treatment you're planning to. So that becomes your another indication where you have to open the flap. Then to manage the furcation involvement, there is a furcation area, there is infection through the root. You can see that the patient is having pain. So that's when only that area you have to explore. So that becomes another area where you have to open the flap. So these are the different indications of flap surgery, like where and all you're supposed to be doing these flap surgeries and where and all these periodontal flaps are elevated. So coming to the different procedures, mainly this is just to make your concepts easier. I have divided into two things. Okay. One is pocket reduction surgery. Like you are ready. There is a pocket, periodontal pocket, which is more than 4 mm deep pockets. And to reduce that, you're doing some kind of surgery. So that comes under one section. The second section comes under different kinds of anatomic defects. Like you have probably a bulge or recontouring of the bone or crown lengthening. All that comes under anatomic defects. In broad, let me just explain what these are. Coming to pocket reduction surgery, first of all, you have resective surgery. where you're okay, so this is the resective surgery where you're modifying the bone. Anything when you modify the bone, it becomes resective osseous surgery. Okay, you either contour the bone or remove a bulge, or you make a depth so for that easy contour of the gingiva to come back to its original position. All those are called as resective surgery because you're resecting the bone, you're remodifying the bone. That becomes your resective osseous surgery. And then comes your regenerative surgery. Sorry, there's a mistake in the writing over there. So here, when you add bone grafts or any other in your recession areas, when you're applying another connective tissue graft or epithelial grafts, all those come under the regenerative part of the surgery, or which comes under the flap surgery. What and all comes under correction of anatomic defects? First of all, plastic surgery. So aesthetic surgery, aesthetic plastic surgeries. Now, what are these plastic surgeries? Plastic surgeries, especially in periodontal plastic surgeries, are referred to those areas where you're improving your aesthetic conditions, or the connective tissue or epithelial tissue part of it is being corrected. So if you go to see in this case, you can see there is a root recession over here. You do a proper root planing and then you open the flap. You do the recipient bed, this is called. Then you get a graft tissue over here. Then you place it, suture it, and then you place it back. So that becomes your aesthetic surgeries or the plastic surgeries. Under this, which you will have, epithelial graft, it is taken directly from the hard palate. Though you directly make 2 incisions over here and nicely take a triangular cut and place it on the defect. You also have connective tissue grafts. Okay, connective tissue graft. Basically, in connective tissue graft, what you do, in epithelial graft, you directly took a graft over here, but in epithelial graft, you make the incisions inside. Like, you make a layer inside and only the inner layer, you cut it slowly and then you get that graft. So that becomes your connective tissue graft, epithelial graft and connective tissue graft. So these are also used in flap surgeries. Then aesthetic surgeries are root coverage procedures. The main aim of this root coverage procedure is to coverage the root. There is root recession happening over here. So that's when you place, either you can use epithelial grafts again, or you don't need to use a graft. You can directly shift the position of your flap. Like you open the flap and then you either get it down and cover the flap, or in some areas what you have to do, you have to put it back, like push it more down, like especially in the furcation areas, which we'll be discussing further. That will be your displaced flap. If it is not displaced, or if you're placing it back at the same position, that becomes your undisplaced flap. Again, that we'll be discussing in depth again. Then comes your recreation of the gingival papilla. So here you'll be doing some kind of bone grafting or collagen membrane placement where the recreation of the papilla happens. So that comes under your aesthetic surgery. Then pre-prosthetic surgery. Pre-prosthetic surgery, we know crown lengthening. Crown lengthening here, you can see the difference. There is a difference in the zenith of these incisors. So that's when you open the flap. But the problem in crown lengthening is, you may say that, why? We can just do a, probably do a small cut and just lengthen it. But what happens is, then your gingival sulcus become less. You might even lose the entire gingival sulcus, and that in future might lead to more of gingival recession. So to maintain the gingival sulcus, what we do is we open up the flap and we reduce a little bit of bone. See, in this picture, if you see over here, they have reduced the bone as well. So when you reduce the bone, when you cover the flap, you get some amount of sulcus there. So that's why we recontour the bone. Osseous recontouring is done before the crown lengthening, and then we place back the flap, and then we get the right amount of zenith for both the incisors. Then is ridge augmentation. Now, why is this done? Now, you have a very thin bone, especially in old age and all. Suddenly, around a 40-year or a 50-year-old patient comes and tells, I want implant placement, and there is no 2 teeth over here. So that time, what you have to do, like, you can see the bone is very thin. but you need to make it more thick, because if you have to place the implant, you have to expand the bone, right? So that's when we expand the bone over here. It can be either vertically or as well as horizontally. So that becomes your ridge augmentation. Then comes your vestibular deepening. So in these cases also, sometimes what happens is you have to increase the width of gingiva. In this ortho case, what happened is they don't have enough attached gingiva. So when there is no enough attached gingiva, there is more chances of recession. Plus, if the frenal attachment is high. So what they do, vestibular deepening, they make a cut over here. They split the flap over there, and then they suture it below. So that way, there is increase in the attached gingiva. That is pre-prosthetic surgeries, okay? Then comes your placement of dental implants. In placement of dental implants, you have, there is a low level of bone. So you place the implants. On top of it, you place your bone graft. And then sinus lift grafts. So in this, you have your sinus area over here, but your sinus is very close to the bone level. So when you place the implants, it might go inside the sinus directly. So that's when you lift your sinus, you place the bone graft over there, and then you place the implant. So that becomes your sinus lift grafts. All these we'll be discussing in depth. I just wanted to give you an overview today. Okay. Okay. Now the biggest question everyone has, or at least I had during my UG, was split thickness and full thickness. What is this flip thickness? Why is it done? And when do we have to do split thickness and full thickness? One thing is, in one surgery itself, like when you see this portion itself, you can have both. You can have full thickness and split thickness in one surgery itself. It's not a separate surgery by itself. Split thickness or full thickness flap is in itself is not a separate. But during your different kinds of procedures, or whatever procedures which we spoke about, be it furcation involvement procedure or root coverage procedure or any increasing the width of attached gingiva, anything will include both. It can include both. I'm not telling always it includes. Sometimes it includes only full thickness. Sometimes it includes only split thickness, or sometimes it includes both. Okay. But let's see what is full thickness and split thickness. So full thickness flap is, this is the bone over here. You have the periosteum over here. So along with the periosteum, when you lift the flap, that becomes your full thickness flap. Okay. You can see a clear white bone over there when you do full thickness flap. Whereas when you do split thickness, you don't even go near the bone. Okay, you just through the scapula slowly remove only till the middle of the area. So that becomes your split thickness. Now, why do we do this? Sometimes when we place the grafts and everything, we need some area amount where blood vessels are still there. Like this will be your connective tissue area, right? So in these areas, you will still have blood vessels. So when you place the grafts, there are more chances of it having for adaptation. Better adaptation happens over there, because the blood vessels, they need those for neovascularization, for new vascular tissues to be formed. So if you see this case over here, you can see this is a recipient bed of a flap. That is, they open the flap and they wanted to do root coverage for this patient. So what they have done is they'll now either place a epithelial graft or a connective tissue graft. Now, in this case, this area, now this is the root area. This is the crown portion of it. This is the root area. And this part is the bone over here. Now, in this area, they have done full thickness flap. That means they have gone up to the periosteum and lifted. You can see it being more whitish in color. But same area, if you go to this papillary region, you can see there is some amount of tissues which are still left. Are you able to see those? Yeah. So these tissues are in these areas, it becomes split thickness flap. So in the same surgery, they have used two different kinds of flap, that is called as split thickness as well as full thickness flap. So what is full thickness flap? It exposes the underlying bone by reflecting all the soft tissues, including the periosteum. Whereas periosteum, which is covering the bone, is intact. Here, the periosteum is not lifted up. So if you see over here, in this case, you can see this is what they had planned. So here they will plan a full thickness, and here in the side they will plan a partial thickness flap. So when you do that, what happens is you these areas, when you place the graft tissue, it will help in new blood vessel formation, which will further help the tissue adapt better and the graft to be accepted by the area. So this much becomes your thickness of the flap. Now there is different kinds of classification of the flap, where undisplaced flap, modified Whitman flap, displaced flap, papilla preservation flap, modified papilla preservation flap, and the different various new techniques which we'll be learning in future series. Okay. Now, one more thing I wanted to talk about is the principles of the flap. Now, especially what are the requirements of the flap? Okay. Now, if you see, in each of the flap must be designed to provide adequate exposure. It should be in such a way where it exposes the area. That is principle number one, because it has to have access to that area. So the main principle is you need to open it enough to have adequate access to that area. That becomes your first principle. If you do not get enough access, like if you open little bit and you're like, yeah, enough, I don't want to go more because I'm scared, it doesn't serve the purpose. So your first principle, it becomes adequate access. You should open it up till you get enough access where you can do your treatment perfectly without any interruption. The second should be your flap over here. If you see, your flap should always have a larger, broader base. Now the base area over here should be broader, and it should be converging towards your cervical region. Flap should always have a base and always have a good vascular supply. Now here, if you're doing full thickness, when you go further, you have to make it split thickness to get a better vascular supply. Okay, then incisions of the flap should be made with sharp scalpel incisions. Like the two vertical insertions which you're converging towards has to be sharp. Like you can't keep cutting it over there. So if you do that, you're losing a lot of healthy tissues over there. So that's why a sharp and straight clinical one vertical incision. You can't keep drawing, because you'll be doing multiple cuts. So that's why they say sharp incision. Incisions to be right angle to the epithelial surface. That means if this is your gingiva over here, okay, you're having your gingiva, this is underlying root and everything. It can't be like this, or it can't be like this. The incisions which you're putting, especially the vertical incisions or this thing, everything has to be right angle. It should be at the right angle to the flap. Sorry. Then, while raising the flap, care should be taken to prevent any lacerations or perforations. There should not be any hole in the flap or a perforation. You should have enough thickness of the flap. That's what they mean. It should not be so thin that when you poke it, immediately it tears the tissue over there. So that has to be kept in mind. And the sixth one is, when placed back after surgery, it should be rightly placed at the healthy region. Wherever you were planning the surgery, when you place back the flap, it should be at the right position, and it should not keep shaking. Like the sutures, when you placed also, it should be stiff, as if you have not done any surgery over there. So these are the 6 principles. First one, it should have adequate access. Second one, it should have a broad base and a good vascular supply. Third one, it should be made with sharp scalpels. Fourth, it should be at the right angle to the epithelial surfaces. Fifth, it should be there should not be any laceration or perforation. And sixth, it should rest on the healthy tissue as previously placed. So these were the principles of flap surgery. Now, one more thing which I would like to talk about: what are the requirements of these surgeries? First one, again, it should provide exposure to the operative site. The base of the flap should be wide. What is the wide? How much wide should it be? It should be twice as much of the length of the flap. That is, the base should be twice the length of the the ending part of it. That means this should be almost the double the size. Like if you take this, okay, it should be more than that of the whatever you're looking at the cervical area, it should be double to that on the base part of it. Then to avoid soft tissue trauma during surgical procedure, it should expose the entire site of the operation. And if you should be, whenever you're doing the flap surgery, you should know where you want the bleeding to happen and where you don't want the bleeding to happen. So whenever you lift through the periosteum, you don't find any bleeding because you're directly opening the you're directly going through the periosteum. Very minimal bleeding happens and you get a clean, nice bone which is seen. But when you do split thickness, you will find a lot of bleeding which is happening because there are blood vessels actively bleeding over there. We need that because especially when you place the tissues, the initial part of life where the tissue would have been deprived of all the, the tissue graft which you are taken from the palate, they are deprived of all blood vessels. So you need those little bit of blood vessels, which is like, actively bleeding when you place it on the recipient site. And especially when you're doing these flap surgeries, you should be careful and plan it in such a way that it should not hurt any nerve or any large blood vessels. Imagine a large palatine blood vessel is happening. You can't plan your flap on those regions. So these are the requirements of a flap, periodontal flap. So I think the next session, I want to talk in detail about the different kinds of incisions we give. We'll be talking about circular incisions. We'll be talking about what are the different horizontal incisions. We'll be talking about the vertical incisions. And other than those, what are the incisions used in different kinds of surgeries. So that will be the next sessions of, that is series 2 of this periodontal flap surgeries. Does anybody have any doubt in what we have spoken today? Can we wind up today? Oh yeah, and we also have the Periodontology mind map book, which is already out. We have 2 volumes of it. This is volume 1. So every page will have mind maps. Is it clear or blurred? Yeah, I just... Oh. So please do have a look at it at our website. And every page will have illustrations of each technique, and pinpoints are given of what is important and what is not important. So can you see over here? So these are the different things which will be given. This will be a mind map. So every important topics we have concised because we want you, like just before going to exam, if you have to learn and just do a quick revision, everything is put up in the mind map for you all. Like the illustrations are there, the mind maps are there, the important points are there, important Viva questions which will be asked will be there. So all are like just added in that one book for you all to understand. So thank you so much, everyone. We shall meet again next week for the next sessions. I'll be talking exclusively only on incisions, different kinds of incisions used in periodontal flap surgeries. So yeah, thank you. Good night.
Wait, there's more. But before we go further down the rabbit hole, subscribe to our channel.